We end Unit 2 with Chapter 19, which is covering the knee joint. Motions allowed in the knee joint include flexion, which is 0 to 135 degrees, though you will see some texts that show 120 to 135 degrees. What we will test is the available range is 0 to 135 degrees. For extension, 0 degrees is the norm. However, it is possible for some people to go into hyperextension, which is about 5 degrees or so. Anything beyond 5 degrees is considered a genu recurvatum, which we will cover here in just a little bit. So this is kind of the joint structure and the motions available. The knee is a synovial hinge joint, though it's not a true hinge joint. It does have somewhat of a rotational component. It's an accessory motion. What you need to know is that the femur is convex, the tibia is concave. So we're going to talk about the screw home mechanism, which is that rotational component, here in just a little bit. So this is the bony landmarks of the tibia. We've already kind of covered the tibial tuberosity as an attachment point for the quadriceps muscle via the patellar tendon. But here are some other parts that are going to be need to be known for the knee joint itself, as far as muscle and ligament attachments. These are bony landmarks of the fibula. The fibula itself is not part of the knee joint as well. There is no articulation with the femur. It has a larger role at the ankle, but the fibular head serves as a point for muscle attachment, which is why it is mentioned here. The patella is a triangular-shaped sesamoid bone. It's within the quadriceps muscle tendon. It has a broad superior border and is distally pointed. So you can kind of see why the patella is important here, as it changes the moment arm of the knee joint. So we kind of already briefly mentioned it, that the knee joint actually has a rotational component, and that rotational component is called the screw home mechanism. The medial femoral condyle is longer than the lateral condyle. So as extension occurs, the articular surface of the lateral femoral condyle is used up, while about a half inch remains medially. The medial femoral condyle must glide posteriorly to use all of its articular surface. With knee extension in non-weight bearing, you get some external rotation of the tibia. During a weight-bearing activity, say like squats, or what's called closed chain, you have a posterior glide of the femur, which results in the femur rotating medially on the tibia. This all occurs in the last 20 degrees of extension. So with the patella, we have what's called the patellofemoral joint. Okay, so it's the articulation between the femur and the patella. The patella functions as an increasing the mechanical advantage of the quadriceps muscle, and it protects the knee joint. And there are various dysfunctions that are associated with the patellofemoral joint, and we will kind of talk about those briefly later on. To go along with the patellofemoral joint is you have what's called the Q angle, or the patellofemoral angle. So the Q angle is the angle between the quadriceps muscle and the patellar tendon. This is determined by drawing lines from the tibial tuberosity to the middle of the patella, and from the middle of the patella to the ASIS of the pelvis. Normal angle range is about 13 to 18 degrees, and because a female pelvis is wider, a Q angle is actually greater in females. This angle represents the angle of quadriceps muscle force. Many different knee and patella problems are associated with Q angles greater or smaller than the normal range. For example, you have what's called patellofemoral pain syndrome, which is where patients or runners or weightlifters, people can have knee pain because of a specific muscle imbalance. So here are different variations of the Q angle. So in the middle here, you see a normal alignment, normal Q angle. On the left, you see what's called genu varus. Now, genu is another name for knee, basically, knee joint, whereas coxa, that we learned before, is related to hip joint. So on the left, you see genu varus, or what we're going to learn is called bow-legged. And on the right is genu valgum, which is knock knees. So acute angle associated less than 13 degrees is it's associated with what's called chondromalacia patellae, which just means that the cartilage on the underneath surface of the patella is kind of wearing thin. On the other side, an angle greater than 18 degrees is also associated with this, but you can also have things like subluxing patella, genu valgus, and tibial torsion. We will not discuss a lot of these dysfunctions in great detail, but they are mentioned briefly in your book. Because the hip joint, knee joint, and ankle joint are kind of all within the same kinetic chain, if you have a dysfunction at one, it can actually cause different dysfunctions at the other associated joints as well. So here's kind of another picture of what genu valgus and genu varus look like. The other one on here is genu recurvatum. So remember that is a high extension of the knees that's greater than 5 degrees. A lot of these can be seen in younger children as well, as their bones are not fully developed, or as we age and you see a lot of the elderly or geriatric population, you will see more of the knock knees and bow legs as well. So another alignment or frontal alignment of the knee is what's called the tibiofemoral angle. So the normal angle of this is about 165 to 180 degrees. Genu valgus is defined as less than 165 degrees, and that's associated with coxa varus, which we learned back in the pelvic girdle chapter. Genu varum is associated with greater than 180 degrees, and it's associated with coxa valgus. So kind of here's a review of the bones and the landmarks that you need to know. We'll talk about the calcaneus just a little bit. First, we're going to cover the ACL and PCL, or the anterior and posterior cruciate ligaments. They're located within the joint capsule in the knee and between the medial and lateral condyles. Cruciates means that they cross each other, so they resemble a cross, but they are named by their attachment on the tibia. So remember that, as it is important for your quizzes and exams, and that they provide stability in the sagittal plane. So here's kind of a picture of the anterior and posterior cruciate ligaments. You have the anterior, starts on the anterior surface of the tibia, runs posteriorly and attaches to the posterior side of the femur. And here's kind of a side shot or cross-section shot of it. So we're going to talk about the ACL first. It runs from the anterior tibia to the posterior femur and prevents anterior tibial displacement on the femur and posterior displacement of the femur on the tibia. It is at its tightest point when the knee is in extension. Here's kind of an example of a torn ACL and ACL, and there's what's called the unhappy triad. When you have the triad, that's also mean you're getting a little bit of the medial meniscus as well. We'll talk about the meniscus in more detail in just a little bit. So the posterior cruciate ligament runs from the posterior tibia to the anterior femur and prevents posterior tibial displacement on the femur and anterior displacement of the femur on the tibia. It is tight during flexion. Because most of our injuries happen during an extension phase, the ACL is more affected and more injured than the PCL. So if we know that the ACL prevents anterior tibial displacement on femur and posterior displacement of femur on tibia, and the PCL does the opposite, which one is more likely to be injured during the scenario at the bottom of this page? Patient's foot is planted on the ground. They were hit by a force to their anterior femur, which pushes the femur posterior. Which ligament is most likely to be torn? The answer is the ACL. With the foot planted on the ground, the force hits the anterior femur and pushes it posteriorly. It will stretch this ACL as the femur moves posteriorly. If the force is great enough, it could cause a tear to the ACL ligament. All right, next we're going to talk about the lateral ligaments. So first you have the medial collateral ligament. It's a flat, broad ligament and actually attaches to the medial condyles of the femur and tibia, but it also has some attachment to the medial meniscus. You may see once you have an injury to the medial collateral ligament, this can then cause damage to the medial meniscus. The medial collateral ligament, or MCL, protects against lateral stresses. On the other side is the lateral collateral ligament, or LCL. It's more of a round cord-like ligament, but it has no attachment to the menisci. It's very strong and it's usually seldom injured, but it protects against medial stress. The MCL and LCL functions to provide stability in the frontal plane. Okay, so medial collateral ligament gives you medial stability, and lateral collateral ligament gives you lateral stability. Both of these are tight during extension and slack during flexion. So if a patient was standing or running and they were hit by force to the lateral aspect of their tibia with their foot planted, which collateral ligament would most likely be torn? The answer is the MCL. So here are some other structures kind of associated in the knee joint. So we'll talk about the menisci now. So you have two in each knee joint. They're two half-moon wedge-shaped fibrocartilage discs that have no blood supply. There is no vascularity into the menisci except maybe on the lateral edges of the menisci. So if you have a meniscus tear and the tear is on the outside border, there is some chance of healing. However, deeper the tear goes, the less chance that that tear actually heals because of the lack of vascularity to it. The purpose of the menisci are shock absorption and to deepen the joint surface. So there's the medial and the lateral menisci. The medial meniscus is torn more frequently because of, you remember, its attachment to the medial collateral ligament. The lateral meniscus does get injured and is torn, but probably not as frequently as the medial meniscus. All right, so this next slide just has a picture here of the knee joint and associated ligaments. I've left it where you can now kind of quiz yourself, if you'd like to, on what structures are there. And then here are the answers to those. All right, so next we're going to talk about the different bursa in the knee. So bursa are, consider them kind of like little pillows within each of the joints. Now they are found all over the body, and what they do is they reduce friction between tendons and bony areas or other tendons, so that to kind of reduce injury there. There's approximately 13 located at the knee joint alone, and here are a couple that are probably the more important ones that you need to remember and where they are. So somebody that has what's called prepatellar bursitis, this is the dysfunction in the knee where the bursa, if rubbed in the wrong direction too much, can actually become inflamed and what's called bursitis. And this is a inflammation of the prepatellar one, which we'll go back to this slide and see that it's right there on top of that patella or the kneecap there. And then this is what it kind of results to in the clinic there. All right, so if we move to the posterior side of the knee, this is kind of the area behind the knee, we have what's called the popliteal space. It contains a lot of nerves and blood vessels. For example, the tibial nerve, common peroneal nerve, popliteal artery, and vein as well. It's a diamond-shaped fossa, and then you have the different borders of each of those muscle groups that you can find in the list right here. Where this can become important is it can serve to learn to palpate each of these muscle borders. Is important to know where different dysfunctions may be happening in the knee joint or where you might have some tendonitis, for example. But it's also important that we recognize what runs through this space in the knee so that we avoid injuring those nerves and blood vessels as we do various activities, exercises, or manual work. All right, next is called the pes anserine. So it's Latin for goose foot, but it's made up of the sartorius, gracilis, and semitendinosus attachment. So each has a different proximal attachment, but they all attach at the same distal point. They all cross the knee posteriorly and medially, and orthopedic surgeons will use this and alter this sometimes to provide medial stability to the knee. So anterior muscles of the knee extend the knee, posterior muscles of the knee flex the knee. Muscles crossing the medial and lateral sides help provide medial and lateral stability. So if you look in your books at table 19-2, you can tell the muscles that cross the knee, and not all of those have a major function. So again, we'll talk about the muscles in the knee joint. Some of these have already been mentioned before for the hip. Again, I'm not going to cover each origin, insertion, action, and nerve. That will be your responsibility to know and memorize. But I will highlight various important parts of these muscles. So rectus femoris we covered in the hip joint. It is part of the quadriceps muscle group, which you see pictured here on your right. It is a two-joint muscle, so it crosses the hip and the knee. So you will see that its action is hip flexion and knee extension. So to kind of cover back into Unit 1 where we talked about active and passive insufficiency, because the rectus femoris is a two-joint muscle, what would put it in a passive insufficiency? So the answer is the rectus femoris would be stretched across both the hip and the knee, resulting in passive insufficiency with the hip extended and knee flexed, because those joint positions put the rectus femoris on a stretch at both joints. So if you have trouble guessing or answering that question, please review the definitions of active and passive insufficiency. All right, another one. So now what would put the rectus femoris in active insufficiency? Rectus femoris was actively contracting with hip flexion and knee extension. It would result in active insufficiency because the muscle is being shortened during contraction at both joints. All right, moving on, staying with the quadriceps, this is the vastus lateralis. So it's the most lateral of the quad muscles. The next is the vastus medialis, so the most medial of the quad muscles. And then vastus intermedialis, which is deeper to the rectus femoris, but in the midline there of the quad muscles. All right, we've covered the hamstrings before in the hip chapter as well, but we'll recover them right here. So remember that they all three have a common origin on the ischial tuberosity, but all have different distal attachment points. Now remember, all three are two joint muscles. However, the short head of the biceps femoris is not. So again, you have the semitendinosus, semimembranosus, and then biceps femoris. All right, next muscle we're going to talk about is the popliteus muscle. It's deep to the two heads of the gastrocnemius, which we'll talk about in just a minute. And really the major function that this muscle does is what's called unlocking the knee joint. So it initiates knee flexion from extension. The gastrocnemius is a two-joint muscle as well, so that's why we're talking about it here in the knee chapter. It crosses the knee and the ankle. It's a very strong ankle plantar flexor, but it does do some knee flexion as well. The other reason that the gastrocnemius is important is because it can serve as a knee extensor. With non-functioning quadricep muscles, or the ones that perform knee extension, stance is possible by the glute max and the gastrocnemius muscle. So in a weight-bearing position, the two muscles contract, pulling the knee into extension, as you can see in the picture on the right here. The soleus may assist this as well. All right, so here are some other muscles that you need to know and why they're important. So you have the gracilis, sartorius, and the TFL, which span the knee posteriorly. So these more or less provide stability to the knee and don't really have a prime moving function, mainly due to their size and what angle that they're pulling on. So on the right here, you will see the different contributions of each of those muscles there. So your prime movers of the knee and extension are your four quadricep muscles. Your prime movers of knee flexion are your three hamstring muscles, the popliteus and the gastrocnemius. And here are the different nerves associated in interventions of these muscles. So need to know these. And that concludes the knee joint and Unit 2.